Good morning, everyone, and welcome to the Emergency Advisory Committee on Immunization Practices meeting on November 23rd, 2020. Before we officially open the meeting, I'd like to turn this over to our esteemed director, Dr. Robert Redfield, who would like to address ACIP members, liaison members, and the public. Dr. Redfield?
Thank you very much, and good afternoon, and thank you for giving me an opportunity to join you for this introduction. I wanted to start by just reflecting on a quote that's been very important to me in my life. I mentioned it to a number of CDC staff. It's really a quote of President Teddy Roosevelt's that I think is appropriate at this point in time. And it says, "It's not the critic who counts, not the man," and I'll paraphrase, or woman, "who points out how the strong man or woman stumbles, or where the doer of good deeds could have done them better. But the credit belongs to the man or woman who's actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who knows great enthusiasm, great devotion, and who spends himself or herself in a worthy cause." And I say that because I believe each of you are devoted to a worthy cause, as we are right now trying to get a safe and effective vaccine to the American public. As the case counts rise across the United States, the implementation of the COVID-19 vaccine program is really more crucial than it's ever been before. And I know our nation looks to you all to give your thoughtful and wise advice and recommendations as we stand now in face of growing cases across our nation, complicated more by cold weather, the holiday season, and the increased strain on our health system across this nation. So I really just wanted to take a moment to thank you for your service and just underscore how important the thoughtful work that you are doing now to give the best guidance to how these new vaccines, which really it's very exciting that we now will have, I think soon, 2 vaccines available to distribute to the American public. And I just want to thank you for being in the arena, making the tough decisions based on the data and your best thoughtful advice that you will give to see how this vaccine can begin to be distributed and ultimately, I believe, will ameliorate this pandemic that we face in the months ahead. So that's what I really wanted to say, Amanda, and thank you for giving me the chance to make a comment at the beginning of your meeting.
Dr. Redfield, this is Jose Romero, Chair. I want to thank you on behalf of all of the members, myself in particular, for those words and those thoughts. I think we will carry those with us through the next weeks as we come to recommendations for this vaccine. We understand the importance of this, and we welcome the opportunity to improve the health and well-being of the American public. So thank you very much for those kind words and words of introduction and encouragement. Thank you.
Well, thank you, Jose, and thank you for your leadership. God bless.
Thank you, Dr. Redfield. Great. So with that, we will officially open our meeting. Dr. Romero, we don't have a gavel, but you can open the meeting in spirit.
Thank you.
So copies of this meeting, copies of the slides being presented today are available until late afternoon on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. Next slide. Next slide. Final 508 compliant versions of the slide presented at this meeting will be posted on the ACIP website after the meeting. In addition, the live webcast videos will also be posted. Meeting minutes are posted on the ACIP website, generally within 90 to 120 days after the meeting. Next slide. These are a few notes related to the virtual meeting logistics that we have today. We ask that all members participating on the Zoom call please mute your lines at all times until you're called on for discussion. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Romero will take questions first from voting ACIP members and then from ex officio members and liaison representatives. We will do everything we can to stay on schedule per the meeting agenda. And if we're running early, we will hold our break until the start time for the next session. And we ask, although my video is on at this time, we ask that ACIP members please disable your video. If you would like to start your video while speaking, you are welcome to. Next slide. The Advisory Committee on Immunization Practices is at its heart a public body. Engagement with the public and transparency in our processes is vital to the committee's work. As part of ACIP's commitment, ACIP has strengthened its oral and written public comment process to maximize opportunities for comment and to make public comment more transparent and efficient. For this meeting, we're holding one oral public comment period this afternoon. The oral public comment period will occur at approximately 4:40 p.m. People interested in making an oral public comment have submitted a request online in advance of the meeting. Priority is given to advanced requesters. And speakers, if too many individuals asked for public comment, speakers selected in the lottery for this meeting will be notified in advance of the meeting. Any member of the public can also submit written public comments via regulations.gov using docket number CDC-2020-0117. Information on the written public comment process included, as well as information on how to make a comment, can be found on the ACIP website. Next slide. Members of ACIP go through extensive forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, we've issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but they're prohibited from participating in a committee vote on issues related to that specific vaccine product. Regarding other vaccines of the concerned company, a member may participate with the provision that he or she abstains from all votes related to that company. At the beginning of this ACIP member meeting, when Dr. Romero conducts roll call, we will ask that all ACIP voting members only indicate their conflicts of interest, declare any conflicts of interest for this meeting. At this time, I will turn it over to Dr. Romero I think he has a few words before we begin roll call. Dr. Romero?
Thank you, Dr. Cohn. So welcome everyone to our meeting for November. Before we begin, I want to draw your attention and the public's attention to an early release MMWR article that will be coming out this afternoon that outlines the ACIP's ethical principles for allocating initial supplies of COVID-19 vaccine. Our primary author on this was Dr. McClung and included multiple members of the ACIP COVID-19 vaccine work group, as well as our chair of the work group and our two co-leads, Drs. Oliver and Dooling. In that article, it outlines the ethical principles that were used for identifying 4 groups for initial vaccine allocation. Now, these groups have not been stratified as of yet and will not be stratified until a final vote is taken. And as pointed out by our vaccine work group chair, Dr. Bell, that we would not do this until we had knowledge of what vaccine or vaccines had been authorized by the FDA. These groups at this time have been selected based on the available scientific data, vaccine implementation considerations, and ethical principles. And in no particular order, they are at this time healthcare personnel and other essential workers, adults with high-risk medical conditions, adults aged greater than or equal to 65 years of age, including residents of long-term care facilities. I think it would be, this will be available this afternoon. I draw your attention to this article. I think you will find it very instructive and illustrative of what we at the ACIP are doing with regard to selection of these high-risk groups. So with that, then I'm going to go forward and take roll call. We'll start with the ACIP members, then ex officio representatives, and lastly, the liaison representatives. For ACIP members, when I call your name, please list your affiliation and if you have any conflicts of interest. So I'll begin now. Myself, Jose Romero, I am the Arkansas Secretary of Health and Professor of Pediatrics and Infectious Diseases at the University of Arkansas for Medical Sciences, and I have no conflicts of interest. Dr. Atmar.
Thank you. Robert Atmar, Professor of Medicine, Baylor College of Medicine. I am a co-director of the Clinical Operations Unit of the NIH-funded Infectious Diseases Clinical Research Consortium that is working with COVID-19 Prevention Network to evaluate SARS-CoV-2 vaccine candidates in phase 3 clinical trials, including those produced by Moderna, AstraZeneca, Janssen, Novavax, and Sanofi. I've also served as a co-investigator on the Moderna vaccine trial. Over.
Thank you. Dr. Alt.
This is Kevin Alt. I'm a professor of obstetrics and gynecology at the University of Kansas. I have no conflicts.
Thank you. Ms. Bata.
Hi, Lynn Bata. I am the immunization clinical consultant with the Minnesota Department of Health, and I have no conflicts. Over.
Thank you. Dr. Bell.
Beth Bell. I'm a clinical professor at the University of Washington in Seattle, and I have no conflicts.
Thank you. Dr. Bernstein.
Good afternoon. I'm Hank Bernstein. I'm a professor of pediatrics at Zucker School of Medicine at Hofstra Northwell. I do not have any conflicts of interest.
Thank you. Dr. Fry.
Hello, this is Sharon Fry. I'm a professor of internal medicine in the Division of Infectious Diseases at St. Louis University. I'm currently serving as the site principal investigator for the Moderna study and the Janssen study. Thank you.
Thank you. Dr. Hunter.
Paul Hunter, Associate Professor of Family Medicine and Community Health at the University of Wisconsin. I own a small amount of Pfizer stock and have a small grant to do quality improvement project on pneumococcal vaccines. Thanks.
Thank you. Dr. Lee.
Grace Lee, Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts of interest.
Thank you. Ms. McNally.
Veronica McNally, President of the Franny Strong Foundation located in Michigan, and I have no conflicts.
Thank you. Dr. Paling.
Kathy Paling, Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine. I have no conflicts. Thank you.
Thank you. Dr. Sanchez.
Pablo Sanchez, I'm Professor of Pediatrics at Nationwide Children's and The Ohio State University, Neonatology and Pediatric Infectious Disease.
Thank you. Dr. Szilagyi.
Hi, Peter Szilagyi. I'm Professor of Pediatrics and Executive Vice Chair at UCLA, and I have no conflicts.
Thank you. Dr. Talbot.
Hi, Kip Talbot from Vanderbilt University Medical Center, where I'm an Associate Professor of Infectious Diseases, and I have no conflicts.
Thank you very much. Now I will turn to the ex officio representatives. For the Centers for Disease Control, Dr. Nancy Messonnier.
Good morning, Nancy Messonnier for CDC. Nice to see you all.
Good morning. For the Centers for Medicare and Medicaid Services, Mary Beth Hance, Dr. Hance. Sorry, she's not going to be here for the roll call. For the Food and Drug Administration, Dr. Fink.
Good afternoon / good morning, Doran Fink for FDA CBER, Office of Vaccines.
Thank you. For Health Resources and Services Administration, Dr. Rubin.
Hi, good afternoon. This is Mary Rubin for Division of Injury Compensation Programs.
Thank you. For Indian Health Services, Dr. Weiser.
Good afternoon. This is Thomas Weiser, medical epidemiologist with the Indian Health Service. Thank you.
Thank you. National Institutes of Health, Dr. Bajel. National Institutes of Health. Very good. We'll come back to that later. Office of Infectious Diseases and HIV/AIDS Policy, Dr. Beckham.
This is David Kim with the Division of Vaccines at the Office of Infectious Disease and HIV/AIDS Policy.
Thank you. Next, we'll move to the liaison representatives. I will not call out your names. Please list your name after I call your organization, please. American Academy of Family Physicians.
Present, Dr. Pamela Rockwell, AAFP.
Thank you. American Academy of Pediatrics.
Bonnie Maldonado, Chair, Committee on Infectious Diseases, Professor of Pediatrics, Stanford University.
Welcome. American Academy of Physicians Assistants.
Good afternoon, Marie-Michelle Léger, American Academy of PAs.
Thank you. American College Health Association.
Good morning, Sharon McMullen, Cornell University, also signing in for my colleague Tavi Chai from University of North Carolina at Chapel Hill.
Thank you and welcome. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Dr. Linda Eckert, University of Washington, representing American College of OBGYN. Thank you.
Good morning and thank you. American College of Physicians.
Good morning, Dr. Jason Goldman, General Internal Medicine, Clinical Assistant Professor at both Florida Atlantic University and Nova Southeastern University. Pleasure to be here.
Thank you. American Geriatric Society.
Ken Spader here for AGS.
Welcome. America's Health Insurance Plans.
Yes, this is Bob Gluckman. I'm Chief Medical Officer for Providence Health Plans. I'm an internist and representing ACIP here today. Thank you.
Thank you. American Immunization Registry Association.
Good afternoon. This is Rebecca Coyle, and I'm representing the American Immunization Registry Association.
Good morning and welcome. American Medical Association.
Sandra Freihofer, Adjunct Associate Professor of Medicine, Emory University School of Medicine, representing the American Medical Association.
Morning and welcome. American Nurses Association.
Chad Riddle, representing the ANA.
Thank you. Good morning. American Osteopathic Association.
Stan Grogg, representing the AOA.
Good morning. Thank you. American Pharmacists Association.
This is Steve Foster representing APHA.
Thank you. Good morning. Association of Immunization Managers.
Molly Howell, Immunization Manager from North Dakota, representing AIM.
Welcome and good morning. Association for Prevention, Teaching, and Research.
Hello, this is Dr. Paul McKinney. I'm Professor and Associate Dean for Research, University of Louisville School of Public Health and Information Sciences.
Good morning. Association of State and Territorial Officials.
Good afternoon. This is Nirav Shah. I'm the Director of the State of Maine Center for Disease Control and Prevention here on behalf of ASTO. Thanks, Dr. Romero.
Thank you for being here. Biotechnology Innovation Organization.
Good afternoon. Phyllis Arthur, Vice President for Infectious Diseases, representing Bio.
Welcome. Good morning. Council of State and Territorial Epidemiologists.
Yeah, this is Dr. Christine Hahn, State Epidemiologist of Idaho.
Good morning. Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Carolyn Kwasniewski, Chair.
Good morning. Thank you. Infectious Diseases Society of America.
Good morning. This is Jeff Duchin, Health Officer for Public Health, Seattle and King County, and Professor in Medicine at the University of Washington, representing the Infectious Disease Society of America.
Good morning and thank you. International Society for Travel Medicine.
Hello, Elizabeth Barnett, Professor of Pediatrics, Boston University School of representing ISTM.
Welcome and good morning. National Association of County and City Health Officials.
Hi, good morning. This is Matt Zahn from the Orange County Healthcare Agency in California.
Thank you. Good morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield from Children's Minnesota, representing NAPNAP.
Thank you. National Foundation for Infectious Diseases.
This is Dr. William Schaffner, Medical Director of the NFID and Professor of Preventive Medicine and Infectious Diseases at Vanderbilt. Hello, everyone.
Hello and welcome. National Medical Association.
Good morning to Pat Whitley Williams, Professor of Pediatrics, Rutgers Robert Wood Johnson Medical School. Thank you.
Thank you. Pediatric Infectious Diseases Society.
Good morning, Sean O'Leary, Professor of Pediatrics at the University of Colorado, representing the Pediatric Infectious Diseases Society.
Thank you and good morning. Pharmaceutical Research and Manufacturers of America.
Clem Lewin from Sanofi Pasteur, representing Pharma. Good morning, everybody.
Welcome and good morning. Society for Adolescent Health and Medicine.
Good morning, it's Amy Middleman, Professor of Pediatrics at the University of Oklahoma College of Medicine, and I'm present.
Thank you and good morning. Society for Healthcare Epidemiology of America.
Hello, this is Marcy Drees, Chief Infection Prevention Officer and Hospital Epidemiologist at Christiana Care, representing SHEA. Thank you.
Thank you and welcome. So that concludes our roll call for today. If there are no other comments or introductions, we'll move on to our first topic, which is coronavirus disease 2019 vaccines, with an introduction by Dr. Bell. Dr. Bell, please.
Thank you. Thank you, and good morning/afternoon, everyone. Next slide, please. So as a reminder, at the October 30th meeting, ACIP reviewed updates from the VRBPAC meeting, which had occurred a week or two previously. We heard about the development program from 2 COVID-19 vaccine manufacturers, as well as updates on vaccine implementation and communication plans. We also had some presentations about post-authorization safety monitoring, ethical principles and modeling strategies for initial allocation of COVID-19 vaccines, updates to immunity and epidemiology, followed by a summary of the workgroup interpretation of data and a discussion of policy questions, the evidence to recommendation framework, and outcomes. Next, please. Now, during October of this year, the COVID-19 vaccine workgroup has continued to meet weekly for several hours. And the topics that we've covered actually it's November, not October, excuse me. The topics that we covered in November included additional discussion of the ethical principles for allocating initial supplies of COVID-19 vaccine. And as you heard from Dr. Romero, an article will be coming out in the MNWR this afternoon that lays all this out in detail. We also covered current evidence in each domain in the evidence to recommendation framework and had further discussions around initial allocation recommendations. Next, please. Now, on today's agenda, we're going to have 2 presentations of the evidence to recommendation framework, again, in preparation for anticipation of votes once the vaccine is authorized by FDA. There'll be first a presentation of the framework domains of the public health problem, resource use, and equity. We'll then have some discussion followed by the domains of values, acceptability, and feasibility. Following these two presentations, we will have a presentation from Dr. Kathleen Dooling around the phased allocation of COVID-19 vaccines. Next, please. Continuing with state of the situation around vaccines at each of our emergency meetings, there are currently over 200 COVID-19 vaccines under development. And in the United States, there are 4 vaccines in phase 3 clinical trials and 6 vaccines in phase 1/2 clinical trials. Next, please. Now, based on information provided by the manufacturers in their press releases, there has been information about efficacy of 2 mRNA vaccines from the phase 3 trials. The Pfizer-BioNTech vaccine, in a final analysis of 170 cases, found 162 cases in the placebo group and 8 cases in the vaccine group, yielding a point estimate of 95% efficacy 7 days post dose 2. The report in the press release gave a 94% efficacy estimate in adults older than 65 years of age. There were a total of 10 severe cases, 9 of which were in the placebo group. The Data Safety Monitoring Board found no serious safety concerns, and an EUA was submitted to FDA by Pfizer-BioNTech on Friday, November 20th. The mRNA 1273 vaccine from Moderna reported an interim analysis of 95 cases, 90 cases in the placebo group and 5 cases in the vaccine group, yielding a point estimate of 94.5% efficacy 2 weeks post-dose 2. There were 11 severe cases, all in the placebo group. The DSMB found no serious safety concerns, and the manufacturer reports plans to submit an EUA soon. I'll also note, for those of you who haven't seen the news this morning, that AstraZeneca and the University of Oxford put out a press release this morning reporting early results of their phase 3 trials in the UK and Brazil. Next, please. So this is a table which provides an update on the COVID-19 vaccines in human clinical trials in the United States. And here you see essentially the 2 vaccines that I just talked about, 3 vaccines I just talked about, Moderna, Pfizer, and the University of Oxford, AstraZeneca. Also is the Janssen vaccine, which is a viral vector non-replicating vaccine with a 1-dose schedule, which is they are recruiting. There's a Novavax is in a phase 1/2, has completed enrollment of their phase 1/2 trial of a protein subunit vaccine, and Sanofi GSK is still recruiting on their phase 1/2 protein subunit vaccine. Next. This table shows additional vaccines in phase 1/2 trials in the United States, including 2 viral vector vaccines, one replicating, the other not replicating, and 2 other vaccines that are not in phase 1 or phase 1/2 trials, are not recruiting at the moment. Next, please. Here we see human clinical trials outside the United States, phase 3 trials actively recruiting. And you can see here that there are a number of inactivated vaccines in phase 3 trial outside of the United States. and the Novavax protein subunit vaccine, which is conducting a phase 3 trial in the UK as well. Next. Continuation of the previous slide, which shows viral vector vaccines, non-replicating, and RNA vaccines. These are the vaccines that are in phase 3 or phase 2-3 trials. In addition, there are 7 non-replicating viral vaccine candidates and 7 RNA candidates in phase 1-2 trials outside the United States. Next, please. So in closing, I show you again the list of our work group members, and you can certainly see them here. It's a very large and very dedicated group of people who I would like to thank individually and also as a group. Next. And these are the CDC participants. Again, a very dedicated group of people to whom we are quite grateful for their expertise and work on this topic. Next. And that's the end of my presentation. Thank you very much.
Thank you. We'll move on now to the next presentation by Dr. Oliver, who will talk about the ETR framework, public health problem, resource use, and equity domains. Dr. Oliver, please.
And thank you, and good afternoon or good morning. So today we will be discussing the evidence to recommendation framework. Next slide. Next slide. So the ETR framework is a structure to describe information considered in moving from evidence to ACIP vaccine recommendations, and it also provides transparency around the impact of additional factors on deliberations when considering a recommendation. Next slide. As a reminder, ACIP will undergo deliberations for 2 separate policy questions. First, should a specific COVID vaccine be recommended? And next, to whom should early allocation of COVID vaccine be recommended? Next slide. So the ETR framework will be used for the first policy question if the vaccine should be recommended for the US population. We'll have further allocation discussions this afternoon after the ETR framework presentation. Next slide. So these are the domains used for ETR that we will be discussing today. Each domain has either one or several questions that ACIP will provide judgments for. Next slide. So to help make these questions easier, we'll be changing the vaccine or the intervention in questions to COVID-19 vaccine X to be replaced by a specific vaccine name later. We'll also replace the problem with COVID-19 disease. Next slide. So for the benefits and harms domain, which specifically discusses data for safety and efficacy, we'll be using the phase 3 clinical trial data to inform this domain and won't discuss further today. Next slide. I also want to highlight that we will be discussing a new addition to the ETR framework, the equity domain. Next slide. So the 3 domains we'll be talking about in the first presentation are public health problem, resource use, and equity. The public health problem will not be impacted by individual vaccine characteristics. The overall resource use domain will have minimal impact currently by individual vaccine characteristics, although this will likely change over time. And additionally, the equity domain will be impacted by individual vaccine characteristics. Next slide. So in the next presentation, we will discuss the values, acceptability, and feasibility domains, all of which will be impacted by individual vaccine characteristics. Next slide. So the presentations today will focus on the current evidence and work group discussions around each ETR domain for future COVID-19 vaccines, and areas where the ETR judgment may vary by individual vaccine characteristics will be identified. As a reminder, there is no vote today. Once the phase 3 clinical trial data and an FDA decision are available, the ETR framework for a specific vaccine will be presented. Again, as it is expected that the information will continue to evolve, the ETR framework and vaccine recommendations will continually be evaluated and updated as needed. Next slide. So the first domain we will address is the public health problem. Next slide. The main question associated with this domain is COVID-19 disease of public health importance? The additional questions to help inform this discussion include, are the questions serious? Is it urgent? Are a large number of people affected by COVID-19? And are there disadvantaged groups or populations disproportionately affected by COVID-19? Next slide. So for each domain, we will be reviewing the available evidence to help us answer questions addressed by the domain. For the public health problem, as of November 21st, there have been over 12 million cases of COVID-19 in the US, with a cumulative incidence of 3,670 per 100,000 population. Next slide. The cumulative hospitalization rate between March 1st and November 14th was nearly 230 per 100,000 population. Among those hospitalized, nearly 1/3 required intensive care and 15% died. As of November 21st, there have been 255,000 COVID-19 associated deaths reported in the US, and estimates of the SARS-CoV-2 infection fatality ratio range from 0.5 to 1.4%. There are other biologic factors associated with increased incidence, including age and the presence of underlying medical conditions, which have been presented at earlier ACIP meetings. Next slide. So based on the review of the EPI data presented here, as well as the EPI data that have been presented at prior ACIP meetings, the work group judgment was that yes, COVID-19 disease is of public health importance. Next slide. So moving to the resource use domain, next slide. So the primary question for this domain is COVID-19 vaccine X a reasonable and efficient allocation of resources? With additional questions including what is the cost effectiveness of COVID-19 vaccine X, and how does the cost effectiveness change in response to changes in context, assumptions, etc. Next slide. So the work group reviewed estimates of economic cost related to COVID-19 vaccinations, disease outcomes, and disease mitigation activities in coordination with NCIRD and ACIP's lead economist. Next slide. Next, for a summary of the evidence, this involves a balance of the cost of COVID-19 disease and the cost of COVID-19 vaccines. For the cost of disease, it's been estimated that if 20% of the US population is infected with COVID, the direct medical costs could be $163 billion. Health-related costs of COVID-19 disease, including premature deaths, long-term health impairment, and mental health impairment, have been estimated at $8.5 trillion. Next slide. For costs associated with COVID-19 vaccines, the US government has committed at least $10 billion to Operation Warp Speed for the provision of vaccines. In addition, vaccine doses purchased with US taxpayer dollars will be given to the American people at no cost. Next slide. So for the workgroup interpretation, there are no published cost-effective analyses currently available. The precise cost-effective analysis and economic impact of vaccination depend on a number of factors that are currently unknown, including the duration of vaccine protection, vaccination coverage levels, and implementation costs associated with a large vaccination program. The workgroup concluded that cost effectiveness may not be a primary driver for decision-making during a pandemic and for a vaccine used under EUA. However, this will need to be reassessed for future recommendations. At this time, the differences by individual vaccine characteristics is minimal relative to the overall scale of the pandemic. However, when cost effectiveness is reassessed for routine implementation, individual vaccine characteristics will need to be taken into account. Next slide. So based on these discussions, the work group felt that yes, COVID-19 vaccine X is a reasonable and efficient allocation of resources. Next slide. So finally, we will discuss the new equity domain. Next slide. The question for this domain is, what would be the impact of COVID-19 vaccine X on health equity? With additional questions including, are there groups or settings that might be disadvantaged in relation to COVID-19 disease burden or receipt of COVID-19 vaccine X? And are there considerations that should be made when implementing the COVID-19 vaccine X program to ensure that inequities are reduced whenever possible and that they are not increased? Next slide. For a review of the available evidence on equity, we first worked to identify groups that might be disadvantaged in relation to COVID-19 disease burden or receipt of a COVID-19 vaccine. This was done building upon other work that has been done in this area using a Progress Plus system. Progress Plus is an acronym to identify factors associated with unfair differences in disease burden, such as place of residence, race or ethnicity, occupation, gender or sex, religion, education, socioeconomic status, social capital, disability, or other. A review of the scientific and gray literature was conducted, in addition to reviewing CDC COVID-19 response data and resources. Next slide. Data from several specific populations were used to inform this discussion. First, for people from racial and ethnic minority populations, while only comprising 40% of the US population, racial and ethnic minorities comprise 50% of COVID cases and 45% of COVID deaths. Age-adjusted hospitalization rates are approximately 4 times higher among racial and ethnic minority groups compared to non-Hispanic white persons. Inequities in social determinants of health put racial and ethnic minority groups at increased risk of COVID disease, including discrimination, lack of healthcare access, overrepresentation among essential workers, low income, and crowded housing. The next population addressed was people living in poverty or with high social vulnerability. COVID-19 cumulative case rates are 1.5 times higher in high versus low poverty counties, and 1.3 times higher in counties with high versus low social vulnerability. Next slide. Next, for essential workers, large outbreaks have been reported in multiple essential industries, and racial and ethnic minority populations are disproportionately represented in subsets of essential workers. There are disadvantaged groups of note with data presented here as well, including justice-involved persons, persons experiencing homelessness, persons with disabilities, persons with substance use disorders, and sexual and gender minorities. Next slide. There were additional considerations for the equity domain. Although COVID-19 vaccines will be provided at no cost, personal investments in time and travel to obtain the vaccine may be a barrier for some groups. And importantly, characteristics of specific vaccines, including the storage and handling requirements, have the potential to greatly impact equitable distribution of COVID vaccines. Ultimately, the work group felt that equity could not be adequately assessed apart from these characteristics and had different assessments for the impact of health equity for different vaccines. Next slide. There were additional questions to inform the equity domain. Are there considerations that should be made when implementing the COVID Vaccine X program to ensure inequities are reduced whenever possible, and if so, and are they not increased? The work group discussed various considerations, including ways to identify groups disproportionately affected by COVID-19 or who face health inequities, undertake focused outreach and education, identify and address barriers to vaccination, and conduct active follow-up of disadvantaged groups to ensure completion of a 2-dose series, or consider 1-dose COVID vaccines for a group where follow-up may be difficult. Next slide. The work group felt that the successful implementation of a COVID-19 vaccination program and confidence in COVID-19 vaccines are pivotal to reducing health inequities. A quote that resonated with the work group, representing the importance of an equitable implementation of the COVID-19 vaccine programs, is provided here. Increasing the availability of an effective intervention within a country or region is not necessarily enough to reduce inequities. The intervention has to be accessible, acceptable, effective in, and used by the most disadvantaged groups within that population to be truly effective at reducing inequities in health. Next slide. When reviewing available data on the epi of COVID-19, as well as characteristics associated with individual vaccines, the work group discussed the impact of COVID-19 vaccine X on health equity. Specifically, for a vaccine with ultra-cold chain requirements, limiting where a vaccine could be provided, there was concern that this particular vaccine, when considered alone, would probably reduce health equity. However, a vaccine that could be used in a broad range of vaccine providers or one-dose vaccines could probably increase health equity. Next slide. So in summary, next slide. These are the 3 domains discussed in this presentation, with the work group judgment summarized here. And we want to receive input from ACIP on each individual domain. So we'll take them one at a time. Next slide. So first, I'm happy to take questions on the data presented for the public health problem and want to ask ACIP if ACIP agrees that COVID-19 disease is a public health problem, and if there's any additional information that ACIP needs to see related to the public health problem prior to a vote. Thanks.
Thank you for that presentation. While everybody gets ready with their questions, we're going to do this a little bit differently today in that at the end of each answer period to the question that was asked by an ACIP member, I will ask if other members have comments related to that question before taking the next question. It'll become clear as to what I'm doing when I actually do it. So that's a little bit of the difference here. So I see Dr. Hunter's hand is up. Dr. Hunter, go ahead.
Yeah, I just wanted to thank everybody who's put so much effort into this wonderful and clear presentation, making our input very easy to address, if not easy to decide on. I just wanted to say that I agree that COVID is a large health problem that needs to be addressed, and I don't need any additional information to decide about that issue. So that's all I wanted to say. Thanks.
Any comments to the comments by Dr. Hunter? Hearing none. Dr. Paling, please.
This is Kathy Paling. So first of all, thank you to the entire work group and all that contributed to this great presentation. It was extremely well done. I'm going to concur with my colleague, Dr. Hunter, in saying that the data presented in COVID disease is a major health problem, and I do not need any additional information. Thank you.
Any comments to those comments by Dr. Paling? None being. Dr. Szilagyi, please, your comment and question.
Yeah, I just want to concur as well, both that this is an excellent presentation, as they all have been about COVID, and that I agree that this is a very serious public health problem, and we have enough information.
Thank you. Any other comments to Dr. Szilagyi's? Dr. Bata, please.
I just echo what my colleagues have just said, that thank you for this presentation. It was very, very clear. I don't feel the need for additional information and do agree that this is a public health problem. Thank you.
Thank you. Any comments to those of Dr. Bata? All right. Anyone else have any questions from the voting group or comments? Okay, very good. Are there any questions or comments from the liaisons? I see none. Okay, very good. So it appears then that everyone is in agreement with the assessments, and there are no further comments. Is there any other further discussion, or should we proceed to the next? I see we have a break coming up. Sarah.
We can go to
you're next. I'm sorry.
Yeah, no, the resource use. We have another. Sorry, next slide.
Yeah. Next slide. Okay.
Sorry, so we can take each of the domains. So regarding the resource use, does ACIP agree that COVID-19 vaccines are a reasonable and efficient allocation of resources? And if there's any additional information that ACIP needs to see before a vote on the resource use. And once we take this question, we have one more question on the equity domain. But I'll pause.
Thank you very much. Yep. Okay, so we're going to go forward here. Dr. Szilagyi, your hand was up first.
Yes, thank you. I'm one of the members that are very often pushing for cost effectiveness analyses. In this case, I absolutely agree that we have sufficient information without specific cost effectiveness analysis, that this is a reasonable and effective allocation of resources. Down the road, when we have multiple vaccines and we are actually voting on and assessing different vaccines with different levels of effectiveness for potentially different populations or subgroups, then I think resource allocation will become more important. But at this time, I feel I have enough information. Thank you.
Any comments to those comments? I see none or hear none. Dr. Paling, please.
This is Kathy Paling. I'm going to concur with Dr. Szilagyi that the approach that we're taking for this unprecedented pandemic is appropriate and reasonable. The additional information that we need to see before we vote is that exact data on from the companies on what the trials really showed, safety and the effectiveness. And so, but for right now, we have as much information as is available, and I very much appreciate this presentation.
Thank you. Anyone else want to make a comment with Dr. Paling's? All right. Dr. Atmore, I see your hand is up.
Yes, thank you, Dr. Romero. I want to echo the earlier comments about the great presentations that have been made both in this meeting and prior meetings. And I agree that this is a reasonable and efficient allocation of resources. The additional information I would like will not only relate to the efficacy and safety of the vaccines, but any additional issues that might arise in terms of distribution, particularly as was pointed out in the presentation, the concerns about cold chain. Over.
Anyone from the voting members wish to make a comment to that? Hearing none, we'll move on to see if there are any other comments or questions from the voting members. I am not seeing any. So let's open this up to questions or comments from the liaison groups. Again, I am not seeing any. So we'll turn it back over to you, Dr. Oliver.
Thank you. And so finally, for the equity domain specifically, does ACIP agree with the work group conclusions for the equity domain, acknowledging that the conclusions depend on individual vaccine characteristics? And is there any more information regarding the equity domain that ACIP would need to see prior to a vote about equity? Thank you.
Open for comment, discussion. Dr. Szilagyi.
Yes, This is a much tougher one. But I think the presentation was excellent, and the discussion about the potential reduction or improvement in equity depending on the vaccine characteristics was right on point. I just want to add that there are, to me, at least two other dimensions that are extremely important. One, which we'll be discussing a little bit later, I think, is the interest in the vaccine by the subpopulations, particularly minority populations. There are a number of studies, including one that I've been involved in, that showed that minority populations are at this point less interested in a future COVID vaccine, but that may change. But the interest in the vaccine and the second dimension involves resources allocated to ensure that minority populations are given access to the vaccine, and that at the local level, at the regional and local level. And I think it may be that even though equity may be reduced because of the cold chain requirements of one or more of the vaccines, with sufficient resources locally, I think that could be attenuated. Thank you.
Does anyone else wish to add comments to Dr. Szilagyi's?
This is Paul Hunter. I
Yes,
wanted
Paul.
to follow. Can I follow up on that?
Of course you can.
Great. So I think that that local emphasis is really important and a really good point. And I think that the work group has given us a really good process at all levels to think about equity and what might make equity more likely to happen or less likely to happen depending on the vaccine characteristics. And I'm hoping that that is really clear into all people who are trying to implement the decisions. And I think it's going to vary by venue. So depending on the exact location that you go to do a vaccine event and the characteristics of the people that are at that site or likely to be at that site is going to make a difference. And if I think then on a sort of hyper local level, the decisions of where to go first to vaccinate and which venue to go to will make a big difference as far as the impact on equity. And I think the people who are deciding which venues to go to first and to emphasize can look to these equity principles that have been outlined here to help guide that. So that's my comments. Thanks.
Thank you for your comments. Anyone else wish to make a comment regarding statements by Dr. Szilagyi and Hunter?
Yes, this is Grace Lee. I guess I just wanted to say that it will be, potentially harder with certain vaccines given their characteristics. But I do also want to just remind ourselves that we shouldn't go in with that mindset, that, we do need allocation of resources to support not just implementation, but equitable implementation. So while I'm a pragmatic person and recognize that implementation factors will actually play a role in accessibility, I would say that it's really important for us to really be able to advocate and highlight the need for resources for equitable implementation, because we do need to support access, acceptability, and use of vaccine, regardless of characteristics. Again, I know that there are going to be challenges, but I think it behooves us as a nation to be able to invest those resources to be able to make sure that if we only had one or two vaccine products, that we would be able to provide access to all populations.
Thank you. Ms. Bata, you're next.
Thank you. Kind of on the same lines as Dr. Lee and Dr. Hunter, as we talk about healthcare workers as a priority, I think it will be important to delineate the ease of what would be easiest in terms of implementing versus what is equitable. And I think that that may be some additional guidance that needs to be clear as local jurisdictions begin to use this vaccine, that sometimes the ease needs to be set aside so that there is equity. Thank you.
Thank you. Any comments on Ms. Bata's comments, please? All right. Dr. Whitney Williams, I see you up there, but let me go to the voting members before I call on you, please. I'm sorry. I will call on you. Dr. Paling, please.
This is Kathy Paling, and I want to say thank you to the work group and all that have been thinking so much. I think the equity domain is extremely difficult, but also extremely important, and this is not going to be easy. In investing so that we can truly have equitable distribution and implementation is going to be a very important focus for everybody to make this vaccine and really change the course of where we're going. Thank you.
Does anyone wish to add additional comments? Okay. Ms. McNally.
Thank you. I just wanted to follow up on Dr. Lee's comments to state that I agree with her position on this, and to state that we really will need to give full consideration to how we can get these to the affected communities.
Thank you. Any additional comments? Hearing none. Dr. Whitley Williams, do you wish to make a comment?
Yes, I do. Thank you, Dr. Romero. Can I do so at this time?
Please do so.
Yes, so I certainly agree with the comments made by Dr. Lee, and I just wanted to say, representing the National Medical Association, is there have been efforts over the past several months to really reach out to the providers within the National Medical Association, most of whom represent or practice in Black and Brown communities. And as was shown, they have been disproportionately affected by COVID. And so agree, let's not go into this with looking at whether it's accepted or not by higher risk groups, but rather than, how can we make this more equitable? And I just wanted to state that it really is our responsibility to educate the public and really to convince them that this is, if the vaccines are approved, that they are very safe and worthwhile. And that, again, through the providers, patients listen to their providers. I have a feeling if some of the earlier surveys were done at this time, particularly with the rising numbers, we may see an increase in acceptance from all the outreach that's been done to this point. But thank you for allowing me to speak.
Thank you. Anybody wish to add comments to that? Okay, hearing none. Dr. Freihofer, please.
Sandra Freihofer, the American Medical Association. As many of you know, the American Medical Association now has a Center of Health Equity. And I think the adding equity as an additional consideration and part of our deliberations and the evidence to recommendations framework has been so important. I have greatly appreciated all the discussion I've heard at these meetings regarding equity and inclusion. And I really thank the ACIP members who, in their questions to the pharmaceutical companies and to the pharmaceutical companies themselves, particularly Moderna and Pfizer, for publishing the diversity of their participants online. This, as we talk about vaccine confidence, having this information online for everyone to look at, this adds to the transparency of the process and is so important. So many thanks to all of you on ACIP for all of your thoughtful discussions.
Thank you for your comments. Anybody else wish to add something to those? Okay. Dr. Dushin, please.
Good morning. Thank you. I also wanted to re-emphasize that how inexorably intertwined equity and implementation is. It's appropriate and necessary to consider equity and to make recommendations, but it will be not possible to deliver unless we adequately fund and resource the implementation that is necessary, the planning at the state and local levels. And it's been gratifying, amazing, and appropriate to see Operation Warp Speed bring to these new vaccine products to fruition in such a short time. But with respect to state and local health department planning, it's not been Operation Warp Speed. It's been closer to Operation Status Quo. And we need to make sure that we have these resources available at the state and local level so that we can put plans in place to do everything that is needed in this highly complicated implementation. Thank you.
Thank you for your comments. Anyone else wish to add to that? Okay. Dr. Szilagyi, go ahead, please.
Yeah, I think we're hearing a resounding, essentially everybody who's spoken is saying the same thing. And I just want to mention a couple of other points. One is the points about the surveys about the populations and subpopulations and their interest in the vaccine. I think that interest in the vaccine is modifiable. And I think interest in this vaccine may be more modifiable than confidence or hesitancy in other vaccines, where there's more entrenchment and hesitancy for other vaccines. And I think some of the modifiability has to do with what many individuals were talking about here, which is accurate information, more education, information about the types of individuals who were ethnic and racial backgrounds of individuals who were in the trials, early experience in the vaccine, particularly with healthcare providers and many other. Some of the data that I have is that the interest or hesitancy in a COVID vaccine is very related to the concept of trust. And I think trust can be built with transparent processes such as we're having here. And one final comment, several hundred years ago, a medical professional said that the amount of resources devoted to a health problem should be proportionate to the need. And the need isn't just healthcare need, the need is social need. And access and difficulty in access is, in my mind, a need. So we need to devote more resources to subgroups of our population who have greater difficulties in access. Thank you.
So if I could add some comment to that last commentary by Dr. Szilagyi, that education, that information that needs to be provided to those groups that have some degree or significant degree of reluctance needs to be appropriate to the group. And that may mean targeting, looking for, identifying ways of diffusing the information to groups that normally do not seek information from our usual means of transmission. And that may mean identifying individuals in communities that are thought leaders or influencers to change the current perception or perceived perception of the vaccines. So I'll stop there and see if anybody else has comments. Very good, Dr. Fry.
Thank you. I would like to also agree, Jose, with what you're saying and just point out that it is sometimes difficult to get into the populations that we are discussing. However, those of us who have been doing vaccine trials have found that if we engage the population, engage the leadership, provide educational pieces, that the reward is amazing about the change in opinions based on educational pieces and the number of individuals from disadvantaged groups who have come out to participate in these studies. So therefore, I'm translating that, if I can have that, take that leeway, that I think very strongly that if we take the time to go into the communities, engage leadership, and do those educational pieces in the community, we will be remarkably surprised, and people will be more accepting, if you will, of being vaccinated. Thank you. Thank you.
Any comments to Dr. Fry's I hear none. Dr. Zahn, please.
Sorry. Hey, this is Matt. Hey,
Yeah.
yeah, I'm sorry. I was muted. I apologize. Can you hear me?
Yes, we can. Go ahead, please.
Yeah, just following up on Dr. Duchin's comments, again, from a local public health perspective, resource is just going to be critical for this. And I think that there's obviously the need to find resources to communicate to the at-risk populations, particularly disadvantaged populations, and get the vaccine to them. I think another critical part that we have to think through is I think we're presuming and recognizing the need to gather information on everybody who gets vaccinated, which involves immunization registry and electronic reporting, both the vaccination and any adverse side effects, and that is really important. But I suspect on a local level it's going to operate in tension with our attempt to use resources and get out to populations that are harder to reach. And so I don't have an easy answer for it. I would just note that it's going to be really important to realize as we're trying to gather that data, and that those are two things that are not necessarily going to be easy to do together. Get the vaccine out and gather a lot of data electronically quickly on the people who are getting vaccinated.
Thank you. Does anyone wish to add to Dr. Zahn's comments? Okay. Anyone else from the voting? Sorry. Here we go. Dr. Stinchfield, please.
Yeah, Patsy Stinchfield from NAPNAP. I just wanted to add to Dr. Szilagyi's comment about subgroups. And as more pediatric data becomes available in children participating in the trials, we will need to make sure that our equity domain also includes age equity, so that we have pediatric children of color as well as children of all ages. So more to come in the future as we get more data on this vaccine in kids. Thanks.
Thank you. Does anyone wish to make additional comment on that? Okay. I'm not seeing any other hands up. Just want to make sure, either from the voting members or the liaison groups. All right, I don't see any. Let me ask Dr. Oliver if she needs anything else from the voting members or the liaisons.
No, thank you, Dr. Romero.
Thank you then for that for that excellent presentation. So we're going to take a break. We are scheduled to return at 1:30 PM, and we'll see you then. Thank you all very much.